to introduce. I'm going to introduce our speaker today. He's our first external speaker for SimCity rounds. This is Dr. Jerry Maniate, and he's an associate professor in the Division of General Internal Medicine in the Department of Medicine and Department of Innovation in Medical Education at the University of Ottawa. He's a clinician investigator and is part of the clinical epidemiology program at the Ottawa Hospital. And today he's going to be talking to us about exploring the role of collaborative partnerships and simulation to further health equity. And Jerry is also a leader in the Equity in Health Systems Lab, which you'll probably be telling us more about today. So without further ado, the floor is yours, Jerry. Thank you.
Thank you, Petal. I just want to make sure that people can hear me well, and if you can, a thumbs up, that's great. Thank you very much for the opportunity to be here with you. And I feel now there's an added weight that you said that I'm the first external person to be presenting at these rounds. I do still feel a strong connection to Toronto because of my about 12 years that I had spent in Toronto, working at St. Joe's, being at the Wilson Centre, being at the Centre for Faculty Development, all places that have really impacted my work and the networks that I have. And so as we talk this afternoon, there will be some of those elements that you will see coming in as well into the work that I'm currently doing. And so thank you again for the opportunity to be here. So in terms of as we start our time this afternoon, I do want to acknowledge that I am in Ottawa, and which is the traditional and unceded territory of the Algonquin people. I've been very fortunate throughout my life to have lived in a number of places. First being born in Winnipeg, which is the traditional land of the Anishinaabe, Inuit, Oji-Cree, Dene, and Dakota, and is the birthplace of the Métis Nation and the heart of the Métis Nation homeland. I've also had the opportunity to be in Toronto, as I mentioned, for about 12 years, where many of you are located, and then it is the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I look back on each of those locations, and I acknowledge that there was so much that I didn't know, and so much that I've learned in the process of being in these places. It's really allowed me to struggle with the truths that I keep hearing about and listening to, and realizing that there's much that I have to work when it comes to the reconciliation that I need to have with these truths, with our Indigenous people that have inhabited these lands, the past traumas that they have faced, as well as the current and future harms that many of them are facing. And so I always look at this acknowledgement as not just a statement that we often will say at the start of these type of sessions, but also it forces me to reflect just where am I at this moment, and what am I doing to be part of that process of reconciliation, both as an individual, as a family, but also within the community that I work within. And I hope that you will take that kind of opportunity as well in situating yourselves. In terms of conflicts of interest, I acknowledge that I have my own history and biases and beliefs and values that I will likely be still wrestling with as part of this work, because oftentimes these things are unconscious. There are other areas that I've been working in that relate to the topic that we're going to be talking about today. And so first, I'm the founding director of the Equity in Health Systems Lab, and I'm also the Team Primary Care Project EDIA cross-cutting team lead. I've received some grants as well from these entities with regards to this work as well. So this afternoon, I'm going to be presenting us with some ideas which may make us uncomfortable, which may hopefully challenge where we find ourselves, which may disrupt the worldviews that each of us hold, and it may create some tension in the social relationships that we currently hold as well. My desire, though, is not to be unsafe, to find things that will actually threaten or harm or add stressors into how we think. And so it's important to distinguish between the two. Being uncomfortable is reasonable, being unsafe is not. And so I acknowledge that this is a work that I'm doing, that I'm trying to engage with authentically, and I acknowledge that there may be times in which I may make a misstep. And so I ask for grace. And if that does happen, please reach out to me by conversation, by email, and I'd be happy to connect with you. As we do have this conversation, especially when we talk about equity, it's important to acknowledge the space that we're trying to create as we have these kind of conversations. Some of what we'll be doing will be individual, but I will also have times where I will ask for engagement from the audience. So I would ask that we allow for others to speak for themselves, to explain where they're coming from, to listen with resilience, to hang in there when we hear something that may be a little tough or hard to hear. And bottom line as well, keep the stories here. You can share the ideas and the concepts. And I encourage you to do though in order to stimulate the conversation in the communities that you find yourselves in as well. So to start us off, I wanted to start with a video clip that's pretty self-explanatory. I want you to think about what's going on, what's happening, and are there links to what you're seeing with the context that you find yourselves in within the health system, within your health professions education programs as well. So I'm going to play this video. It's very short, and then we'll just have an open time for some debriefing on it. So, what was going on, and maybe more importantly, what was being permitted to occur in this space? And I'll try and keep an eye out for hands on the screen.
I can watch a chat for you, Jerry.
Thank you. Jordan, thanks for that comment there. Comment, carry on. Absolutely.
Yeah, they looked all extremely heavily dressed for the weather.
Yeah, the context was this was Prince William at a parade, but it was like 30 degrees out.
Yeah.
These are woolen tunics and bearskin hats, and the show must go on, as it were. Priority setting seems off. Yes, Doug. Yeah, unbelievable rule following. Walter, thank you. Were there other thoughts?
It was interesting to me that the guy was on the floor for such a long time, and the other members of the band, it just kept playing and didn't even bother to, at least one person could have, leaned over and said, "Are you okay?" and helped him up. But to keep playing throughout the time he was on the floor seemed really sad.
It was, and it wasn't that they didn't know that this had happened, because as soon as the gurney and the team came around, the person on the end basically said, "It's that person right there, right? They're the one who went down." Yeah, it is hard to believe that this was a real event, right? Yeah, I think that's Carol that put the comment there from Radical Connections. Yeah, contingencies were in place, but people knew it was going to go badly. You think about all the things that were happening, and yet they kept going. Yeah, extraordinary pressure to follow rules, expectations over showing compassion. Yeah, great thought there, Tim. Yeah, and it's fascinating that this happened. Yes, Elaine, yes, this happens in everyday life. And we kind of look at this video and say, oh my goodness, that's so far-fetched. Like that would not happen in our context and where I find myself. And I think this is the question that I wanted to ask next, which was, and Elaine's comment there is a nice segue into, can we apply what we see in that video to what's actually occurring in our health system? Right? Are there actual applications, or is it so off that no, that could never happen here? Yeah. Jacqueline, you say bystander effect. You want to elaborate a little bit more?
Yeah, sure. It's when everyone's waiting for someone else to do it. And maybe they do actually have empathy, but they're waiting for someone else to step in first. And what ends up happening in that situation, the effect is nobody does anything because everyone's waiting for someone else.
Yes. Yeah. And Jordan, you've got some interesting points there that you mentioned. Most EDs look like this to a degree, brittle systems. Do you want to elaborate a little bit on that?
Sure. I guess the comment before of like knowing that there are things about this structure that we've set up that are going to fail, but that people are going to feel like it's their mission to continue.
Yeah.
I think that's analogous to what we see, not just in EDs, but in everywhere in health services of, knowing that these systems are lack adaptive capacity and are not really resilient systems. Yet
Mhm.
we feel like it's our, as the sharp edge of these things, we feel like it's our duty to continue to perform and continue to meet the objectives, regardless of the poor decisions that were made about structuring them.
Yeah, it's interesting. Myself and my colleagues have been wrestling with this even just in the last couple of days. Our teams are just exploding with numbers, acuity, the complexity of the patients, and yet it feels sort of like we're these soldiers that are playing in a band. The show must keep going on. People are not coping and not dealing with things, and yet we're saying, well, we have to keep going. The patients need us, without saying what other solutions, what other implications are there on the individuals that are providing the care, but also those receiving the care, because these it's all intertwined, right? As we look at it. And Tim, yeah, your comment there, toxic elements to culture, and that tendency for rules and norms and conflicts. Yeah, this is very true. And I think as we continue in our conversation this afternoon, I hope you remember some of these points, because these are a bit of the underlying threads that unfortunately underpin a lot of the conversation when we think about equity. And I think we have to intentionally look at how do we undo some of those or rectify and find other options. And I wanted to put this up there because I think it summarizes a lot of what we've just been hearing. What you permit, you promote. What you allow, you approve. What you don't condemn, you condone. And I think this is where a lot of the work, we can look at such a stark example on that video, but thinking through where you find yourself working, teaching, living, all those kind of things will have very similar threads that will come through. And so this is about culture change. This is about shifting culture as we have these kind of conversations. And so this afternoon, I'm hoping that we'll get through a little bit of background, address some key concepts, and explore the use of experiential learning as we look at collaborative partnerships and bring those things in together with health equity, and have a little bit of time for conversation. A lot of this work for myself really started accelerating in 2020. And for most of us, we think of 2020, we think of COVID and the upheaval that occurred with that. But there were other societal events that were happening, very significant events in our society. The murder of George Floyd would have been another very significant event. The death of Joyce Echaquan in our own health system, in the way that she did, was absolutely tragic. And there were many other examples of stressors that were impacting a lot of people. And so there was, when we looked at what was happening, not just societally, but our health system and those that are within the health system are a reflection of our society. There was really an awakening that was occurring during this time. And many of those who were in leadership were starting to say, well, how do we actually respond? Because this time was different, it seemed, and it felt, compared to previous other tragic events that may have happened. But it seemed like these all were happening together. And even today, when we look at what's happening in our own societies, in our own health system, this is not even a full list, but this gives you a flavor of all the different tensions and stressors that are happening within our health system and within our society today. And our learners, our faculty, our teachers, our staff are not immune to these pressures and these stressors. And many, in fact, are experiencing a significant harm and significant stressors because of these various issues. And so what we see is we see a system that is really enveloped with conversations of power, privilege, and oppression that are entrenched within our systems, not just our health systems, but also, I would argue, our health professions education systems. And what we see are fragmentations and silos, and underpinning all of this is mistrust that really becomes what is in our system. And you see this when, if you're a clinician, you have a conversation with a patient, it's not the same as it used to be in terms of how those conversations are. And I would argue that those who are in teaching kind of roles would probably face very similar kind of conversations with their students as well. The mistrust that's there, and what you see is the impact that it has. So how do we counteract that? How do we address it? How do we create and foster trust in this type of environment? How do we create a sense of belonging in this kind of space? And so with that, here's maybe a key concept that we can all wrestle with. And then partly it's because this is being talked about in the health leadership space. In our health organizations, there's a lot of conversation about oftentimes the quadruple aim, maybe the triple aim, but this is a progression of those concepts here, the quintuple aim. And one of the things that was added as part of this work is the notion of advancing health equity. And for many of my colleagues, they may understand the other areas, but when you throw this concept of health equity, most of them kind of give you the vaguest of answers because they're not fully sure. Some of them will draw upon what, if they were in medical school, what they learned in their first year, thinking back to social determinants of health. Health equity means addressing unfair and unjust conditions so that everyone can attain the highest level of health possible. Excuse me. And as you can see, this circle that's on the side really outlines a lot of things that, if you look very closely at, are closely connected to the social determinants of health. And that's important. Because oftentimes these are the things that are not thought of within our health system, because it is frankly a healthcare system. It's a more responsive system. And these things require being proactive and identifying and addressing these concerns. But this is the underpinning of what health equity is. And so if you have this in your back of your mind, as you think ahead, sorry, we think about how do we create a sense of belonging and superimpose those concepts of health equity. We realize that there's a continuum of this kind of work that needs to happen. But it's underpinned with lifelong learning and humility, and it takes time and intentionality. I apologize. I just wanted to pause there and just see if there were any reflections on these concepts that I've just shared, because this is important to wrestle with so that as we move into the next part, we can identify some applications. I'm just quickly looking at the chat, and yes, so Tim, I'm going to get to that in a couple of minutes, but there is a real connection between these, at least in the way I view this work. And I think it's especially important in this work when we're talking about equity, we're talking about social justice, and addressing the social determinants of health. So I'll come to that in a couple of minutes. Okay, don't see any hands up, so I don't see any other comments in the chat. So I'm going to move into this next piece, which is also a very important piece. When we talk about the sense of belonging, one of the well-known underpinnings that has to happen is the concept of psychological safety. And there's a lot of work that is being done in this space, and I'm essentially going to summarize a couple of key concepts to help us in our elaboration as we explore the collaborative partnerships and the work in health equity. But when we look at psychological safety, when we see this kind of work happening, it allows for what we see as inclusion. It creates the space for diversity to occur, but then it facilitates the performance aspect of things. And what we see is that there are essentially 4 levels where this psychological safety can appear: inclusion safety, learner safety, collaborator safety, and challenger safety. And as you sort of move yourself upwards through these levels, you'll appreciate that it requires more intentionality. It requires in more safety to permit these kind of things to happen. So, for example, when we look at inclusion safety, to know that you're valued, to treat all people fairly, openly contribute into this conversation, regardless of people's title or position, that's almost like a foundational space to be. You require that in order to get to that next piece of learner safety, where you feel that it's safe for you to actually ask questions, to experiment, to learn from your mistakes, to look for those new opportunities, to ask for feedback. And as you go from being a learner, being more passive, or perhaps even active in that space, and shifting into becoming a collaborator is more active and engaged in this space. You'll actually engage in an unconstrained kind of way, interact with your colleagues. You'll have that open dialogue. You'll actually stimulate and foster constructive debate in that space. But if you want to move even further along, you get to the space where a person can challenge the status quo, to speak up. When they see something or hear something, they can express their ideas and expose problems. As you can see, all of these things require a progression. It is virtually impossible to get to those higher levels if those lower levels aren't actually in place. And so it takes intentionality to actually get to these kind of spaces. Now, earlier I spoke of the word mistrust, and one of the things that we often hear is, how do we build trust into these spaces? And there is often a difference between having trust and having psychological safety. And I think this infographic for me really helped articulate it, and it also looked better than I could ever design something. So the concept of trust, will you give others the benefit of the doubt when you take a risk? Where psychological safety is, will others give you the benefit of the doubt when you take a risk? And so it's different vantage points as we look at it, but these things are related, but they are different. So when we look at things that can foster psychological safety, we can see continuous improvement behaviors, learning from failure and success, thinking about innovations, communication, inclusion behaviors, individual behaviors. All of these are really important to foster psychological safety within a group, within a team, within a unit. And that's really critical. And what we find is that this actually then goes back into that quintuple aim, and you see how it can impact the care experience that the patients have, but also the care team well-being as well. The reality is we're not in a bubble. We find ourselves immersed in this environment that shapes us. The question is it like the playground that actually has many areas where one can explore, play individually, play together, learn from each other as we do these things? It's fascinating when you have kids and you go into a playground and you see your kids doing something that they haven't done before, and you ask them, how did you learn how to do that? And they will point to one of their friends or one of their the other kids playing in the park that say, well, they showed me how to do that. It's fascinating when you can do that. But from a metaphor perspective, there's also a real importance from a safety perspective to create a space where that can actually occur. I think aspirationally, we all hope that where we work, where we're learning, whether it's in our hospital or our health system or in our health education system, that it's like the idealistic playground. The unfortunate reality, though, is for many, it feels like this. It feels like we're under siege. We're like the eye of Sauron is looking at you and is going to destroy you. And it's gloom and doom and potentially even death. It feels like it feels heavy in this space, and it's because there are so many other things that are impacting our experience and allowing us not to necessarily experience this, which is what we aspire to and what we're hoping for, and what we know will make us creative in finding solutions, but we have this as our reality. So then, knowing this, how do we find that sense of belonging? How do we create that? And one of my colleagues, Dr. Minka Chan, often tells me this and says this at sessions: you need to be and feel welcomed in order to feel well and thrive. And I think if we have all these concepts rolling around in our head, as we look at experiential learning methods, the question is, how do we take these methodologies, these techniques that we have at our disposal, how do we bring them into talking about inequities and health equity topics? Now, simplistically, I put this slide together, realizing that there's so many more nuances. But when we look at experiential learning within our system, I narrowed it down to 4 sort of broad topics. One being the clinical kind of space, right? I'm going to go meet with our students and residents in about an hour. We're going to go see a patient at the bedside. We'll actually interact with the patient, provide an assessment, determine some skills, and make some decisions. That's the clinical kind of environment that we find ourselves. Very little technology. Maybe there's high technology if we pull out the POCUS and do some assessments, but it's pretty authentic because that literally is our patient that we're going to be seeing. Many of us work also in spaces where it's simulated, but there's variations of technology and variations of fidelity. Some are playing, working in spaces where role-playing, where roles are designed with cases and other scenarios. And some are working within virtual reality. All of these have unique opportunities to wrestle with the questions of equity, to wrestle with how do we build trust. And the challenge is, what do we need to consider when we use these type of methods to address inequities in the health system? So I'm going to throw this question out and see what are some of the thoughts that you have. It's a pretty smart group. I'm looking at the names. I know you have ideas because you're experts. And so, Petal, if you can keep an eye on the chat as well.
Yeah,
oh, I can see Jen.
Yeah. She's saying, are the basic needs met?
Jen, do you want to elaborate a little bit more?
Sorry, Jerry, I'm eating lunch at the same time. I apologize for being late. Health inequities is, do they have food? Do they have, clothing? Do they have housing? Because without those, foundations, we can't learn. Because they're so focused on trying to survive, there's probably no capacity for learning. So trying to do something experiential from that perspective makes it challenging.
Yeah, it does. And Jacqueline, you raised a very good point. The high fidelity environments that we have can cause harm. Do you want to elaborate a little bit more?
Yeah, I guess we're always aiming for the most authentic, most high fidelity environment. And on paper, that is ideal. But it's not ideal when we're learning. And you can put patients at risk by asking the wrong questions, or and also it puts the learner in a very vulnerable position when they don't have confidence doing that kind of work. So sometimes we just need to balance out authenticity and go for lower fidelity but safer environments.
That's a great point there. Thank you. And Doug, you mentioned here, consider the authentic patient experience, patient perspective. How do we get at that safely? And it's ironic, how often do we engage patient partners in our educational design to actually ask that kind of question? Instead, oftentimes patients are brought in at the last minute, or, as one of my patient partner colleagues always reminds me, they feel like they're asked to put the sprinkles on the cake of the curriculum or the plan that's being put in, but not actually involved with the design or the actual process. And so perhaps that's a strategy that we need to think of, is if there is an engagement of patients more clearly. Tim, you've got, the diagram showed progression towards psychological safety is clearly applicable in this space. Difficult to implement in a way that our learners authentically feel. And I think that's always a struggle with simulation. I remember when I was a medical student and I knew it was a role play. We all knew it was a role playing exercise, or even if there was a simulated patient, you knew it wasn't a real thing. And so how do you instill, that sense that this could be a real scenario, or this could really happen to you, and how can you learn in that? Appreciation for social conditions, Walter. Do you want to elaborate a little bit on that?
Yeah, sure. Well, I think it's just both faculty and learners just need to be aware of the various social conditions that are leading to these inequities.
Yeah.
Which sometimes can be very, very subtle. And so being very explicit about them and ensuring that learners have a good understanding of those ideas, is obviously something to consider when we're building out these experiential learning options.
And it's often difficult because for most, these things remain hidden, and only within areas of trust or spaces where trust is built can an individual may even reveal to a small group what actually are some of these underpinning pieces. You think about it, when we identify ourselves in a group, how deep do we go when we even identify ourselves, right? Petal gave a bio sketch of who I am, but I'm going to guess that if I'm not just going to guess, I know that if I was in a group of family members, my description of myself would be very different, right? Because there's a different sense of trust and connection, right? This is still a very large group of people in which I don't know everyone, so I'm not going to open myself up entirely in this kind of space. With trust and with time and with relational space, those kind of things can happen, and that happens both for learners but also for our patients as well as we struggle with this. There's a lot of really great comments here. Great. And I think the one thing that I really want us to remind ourselves is like the work when we're talking about health equity and dealing with inequities is going to be very different than the kind of processes that we would think about when we talk about how do we adapt experiential learning techniques to learn a new medical procedure or a technique, right? It will look and feel different because we're talking about aspects that are heart and mind issues, right? They're oftentimes deep-seated cultural issues and biases and stereotypes and myths that are within. And so one of my colleagues often, and Dr. Lynn Ashdown is a colleague of ours in the EQHS lab, she says to be a disruptor, you need to be able to gently rock the boat sufficiently to make it uncomfortable for those in the boat, but not so much that the boat tips over, right? I don't know if you've ever been in a canoe or a boat and it feels like that. And it can be very unsettling. It's helpful to know that someone who knows what they're doing is in the boat and can keep things relatively safe. But in doing so, you become accustomed to some of the jostling, and you'll be willing to have a different kind of appreciation of the situation. And so principles as we think about using experiential learning in this kind of space, the concept of making people uncomfortable but not unsafe or threatened is really important. And how do we do that? Allowing people to critically reflect and think is really important. So it's not just run into a scenario, move in, move out, do the debrief, and off you go. There has to be space given, a skilled facilitator to ask questions that open up the conversation, that allow for voices to come to the floor that might not otherwise be wanting to participate. But that's done by creating the safe space. Creating that space for dialogue, it shouldn't be unidirectional. The most powerful discussions that I've seen when talking about power and privilege and hierarchy and equity is when there's a bidirectional or multi-directional kind of space that's happening where conversation and people are adding their voices and ideas into that space. Remember back to being able to not just be a collaborator, but maybe even be a challenger in this kind of space, right? Not passive, but actively engaging in this. And I think part of the struggle is that we don't often provide our faculty or facilitators with the tools. These are unique tools and mentorship that they will actually need to move that kind of work ahead. And so this is a struggle for a lot of us, that these resources are not necessarily there or are found in pockets. I'm going to pause there because I see, so Tim, you've got a comment here. Is there such thing as mastery? And I realize the irony of this term. When learning in the context of equity, like there is in procedural learning. So Tim, in my mind, I think that goes back to your earlier question, which was the connection of lifelong learning and humility, right? I look at myself and my ability to move into this space, I've positionally placed myself with a space of humility, recognizing that when I walk into any encounter, I need to have that lens where I don't know, or I may not fully appreciate the uniquenesses of what's happening in that space. And I don't want to make the assumption that because the interaction went well yesterday with this patient, that today the interaction will be the same based on the previous assumptions that I learned from yesterday. When I walk into each interaction, if I walk in with humility and also curiosity to ask those kind of questions, I wonder why, or why is this happening, or what perspectives are you bringing to the conversation, or do you have on this situation? Asking questions, curiosity, and then pausing and listening for the responses will actually stimulate a lot of the growth. But I don't think you can get to mastery in this space, frankly, because it changes all the time. It's continuously changing. It's dynamic, even with the same individual that you might be interacting with. It's dynamic. And it's partly because they themselves have things that they're wrestling with and moving within that may be internal and external to them. And we are now relationally engaging with them. So I do think that this is different than procedural learning. Maybe I hope I've articulated at least my concerns with how we often think. And that's why this is hard, because we've got a lot of people who are very skilled and understand the concepts of building simulation or experiential learning for procedural or numerical knowledge. But this is tough. This is a tough space. This is not even basic communication kind of skills that we often talk about. This is next level, because it's often a space where you can't actually demonstrate competence.
And Latika, yeah, Latika added something to that, Jerry. She said, and mastery based on whose determination. Is it us or those that we seek to connect with?
That's right. And I think this is the problem. Like oftentimes we say, oh, I'm a master at this, pat myself on the back. Can I get an EPA for that? And off we move on. That's not the case in this space, right? And then you see those who actually demonstrate humility when they have these interactions. It's a completely different space. And so thank you, Latika, for that comment there, and I appreciate that. So I think we need to think about these kind of things. There's an intentionality to it. What's the environment? What's the setting? When we're writing a case, include those from the community. Get patient partners engaged right away to understand what are the pitfalls that we often may not appreciate because of our position of privilege and perspective. As we think about our briefing, as we prep into those scenarios, what do we need to think about? Thoughtfully reflect on the power, privilege, and hierarchy that may be intentionally brought in, but now may also be unintentionally present in the scenario by who's there. Who has the voice, who doesn't have the voice? The debriefing process, the feedback, all of these things have to be thoughtfully considered when you're bringing in the concepts of health equity and dealing with inequity. So as we think about this, I think one of the challenges is that there's a lot of resistance to change. And I think most times it's because we're trying to do this on our own. Me, myself, and I are trying to change the world. We're gonna solve these problems for everyone. The reality is that we don't and we can't, because we don't have the bandwidth, the platform. Sorry, I apologize. We have the opportunity to actually find partners and collaborate with each other. And I would argue that this is a much more sustainable strategy to addressing this kind of work, because it is tough work personally. I tell people this all the time. If I was to do a talk on any guideline or any medical condition, whatever, I'll do it. It can be done. I go in the work of getting the talk pulled together. Sure, there's some time constraints and stress. Sure, but if we talk about this kind of topic, this is often very deep and often very personal for most of us, because there's a personal connection into the topical space. And so then there's an added burden that often we are carrying if you're trying to do this, especially by yourself. And so by finding friends, finding collaborators and partners that you can work with, you can actually move the needle. You can actually move ideas forward. And so I have a very simple strategy. I've been using this for a while in education, and I've adapted it into this work. I always look around, and when we're looking at projects, I want to make sure all these people are around the table, at least as a starting point. Maybe there's others that we'll bring in based on what we need, but we need to bring the content experts, the context experts. We need to bring our target audience voices, like our patients, for example, and methodology experts, bring them all together to try and understand this work. Because we know the pitfalls of what happens when just a group of content people get together and try and design a curriculum. Likewise, context people or target audience and methodology people, it's often lacking or potentially even dangerous because other perspectives haven't been sought and integrated. Remember, if we're looking at the goal of trying to build trust, no better way than trying to actually work together on something, wrestle with something, and explore and co-create and implement something, and actually see that trust built. Now, it's not always a guarantee, because sometimes, I don't know if you've had this opportunity, but you work with a group of people and you feel like you've got a knife stuck in your back. There's going to be a lot of, there's a low trust happening in that kind of a situation, and it's less likely that you're going to work together moving ahead. But most times, if this experience has actually been positive, you will find ways and seek for ways to continue to work together. And I often tell this to the teams that I work with. I say, it's sometimes more important how we do things than more importantly than what we were able to achieve. Because the how will determine whether or not we want to go for a second round, a second phase, a second project, another opportunity. If you get something published and you feel like there are bodies strewn across the way, it's less likely that that's about to happen. It'll be a one and done kind of an experience. So how do we actually think about this? What kind of an approach? And Tim, maybe this will explain some of the thinking that I have in this space. I think first and foremost, it's got to be humility based. You've got to be starting with that positionality, acknowledging that I don't know the answer. And from there, you move into curiosity. You're stimulating the inquiry. You're asking questions, so that, but you're not asking questions for the accusatory kind of thing, like a lawyer might do in front of a witness in front of the stand. You're doing this out of sincerity and authenticity, because you want to learn. You want to understand a different vantage point than what you're appreciating. This is the tough part, though, right? Because oftentimes, especially in healthcare, we're not very good at listening. We're very good at talking, not very good at listening. And this requires intentional listening. As well, listening for diverse perspectives, seeking those diverse perspectives, but having that positionality of humility and curiosity as we're listening. And then as we're listening, pausing, thinking, analyzing, reflecting on what we're actually hearing. No point hearing a lot of stuff and not actually acting on it or reflecting on it and thinking what needs to work. And through that process, a process of unlearning will occur, because there'll be things that you'll be like, oh my goodness, I can't believe I used to think that, or I can't believe I think that. I need to unlearn that. And as we do so, we find other areas that we need to relearn. We'll push into it. And so this really requires a continuous growth mindset, lifelong learning, right? It requires that to be built into this. And as we do so, then we find spaces that we can bring dialogue to happen. Goes back to psychological safety, right? Creating safe, secure spaces, giving grace as we're having these conversations, that we're all in here to learn and not to simply just make a point. And then finally, do something. Find those opportunities for action. Ralph Waldo Emerson said this: what you do speaks so loudly that I cannot hear what you say. And I think that's the problem that we have in our health system, is that we often see a lot of things that are very performative, very tokenistic, right? We walk down the halls of our institutions, we see beautiful posters that talk about diversity and inclusion, and yet people don't feel it on the ground. People feel like they don't belong in their organization. They don't see themselves in their organization. Maybe the organization doesn't even reflect the society or the community that they live in. These are risks that can happen in this work if not done intentionally. Performative, tokenistic, rather than actual changes in performance. And so in the last couple of minutes that I've got here, I wanted to just highlight a really interesting a collaborative opportunity that has been developing over the last period of time between the team at CAMH Education and the EQHS lab. It's been really exciting to meet people who have a like-minded approach. They want to find ways to bring this work to make a difference in what's happening, and we've been working and wrestling with how do we bring the health equity framework that the CAMH team has been developing, how do we bring that into simulation and education kind of spaces? And as a plug, we're going to be doing I think it's a workshop on this at Sim Expo in Ottawa. So if you're able to come up and join us for that. A second project, though, is wrestling with the concept of leadership. And some would say, like, well, how does leadership fit into all of this, especially equity and inequity? Most of the problem here is that most leaders are not even aware of these concepts. And they're the ones that have been perpetuating the performative and tokenistic challenges, because many of them haven't had the experiences nor the knowledge to actually wrestle with these kind of concepts. They may know these concepts from a superficial level, but they don't understand the implications as it applies into their workspace. And so when I look at those two as examples, I see implications with the work that we're doing together collaboratively on the education of trainees, on professional development, improving patient experience and care, improving the experience of those working in the health system. This is all quintuple aim kind of space. And as we see this, it's been really about relationship building, right? And oftentimes in our space, we have a very transactional sense. It's about widgets, it's about how many papers, how many grants and things like that, rather than relationship and trust building. And what I've really enjoyed about collaborating with the team at CAMH Education has been this relationship trust building that is now leading into conversations of where could this take us. So it's been really important because part of the game quote that we have to play being in universities and higher education institutions is that the work that we do often is discounted. It's not often valued in the same way as others who are doing traditional research would. And so by being scholarly as we do this work and shaping the conversation and the dialogue has been really important. As we hear other spaces and places bringing these concepts into what they're doing, that's what we're hoping for. We want to influence those conversations. And what we find is that we're building a network of networks. The group at CAMH has an amazing network of people that they've been engaging with. And likewise, the EQHS lab has had a growing network. And now these networks are interconnecting. And what we're finding is that we're finding ways to build on each other's concepts and scholarship. So what we find is we're moving into a space of cultural transformation. This is actually a change management process. This is not going from Windows 10 to Windows 11. This is like going from a typewriter to a computer. Like this is for many people, this is a radical shift. And a lot of things change when you go through that process. Entire things have to be transformed. What used to be done can't be done any further, but you have to move ahead. Cynthia Whitehead put this quote up at the CAMH education session that happened in April, and it's really stuck with me. The trouble is that once you see it, you can't unsee it. Once you've seen it, keeping quiet, saying nothing becomes as political as an act as speaking out. There's no innocence. Either way, you're accountable. And I think, I hope that as being in this space today, that we've had an opportunity to think about some of these concepts, to explore some of the implications. But I hope there will be also the opportunity that we can find opportunities to collaborate and partner on this work, because there's no way that any one of us can actually push this forward on our own. And it will require not just the collective strength, but also the collective knowledge and experiences to push these kind of issues forward to transform the system that we find ourselves working within, and eventually we will need care from, because that's the inevitable aspect of growing old as we continue on with our work. So with that, I wanted to thank you for allowing me to be here. And we do have a couple of sessions that our lab is hosting in the next couple of days, including one this evening. This is actually a fascinating conversation with colleagues in palliative care, caregivers, and patients on some of their work. You can go to our website to learn more about this. And we're having a session talking about leadership with Dr. Gigi Osler, Ellen Ellie, and Dr. Connie LeBlanc having that session. So with that, I'm going to say thank you and see if there are any comments or questions.
Thanks so much, Jerry. I think a lot of people might have to run to other meetings because we're right on the hour, but just a reminder, our next SimCity rounds will be October 26th at 4 p.m. And Jerry, who will continue to collaborate with us and did a wonderful presentation today. We're so grateful to you, and I hope that this will not be the last time you presented our SimCity rounds.
Thank you.
All right.
I see Walter
Oh,
has.
Walter's got his hand up. Walter.
I can stick around for a few minutes.
Yeah, we can. Let's stay around.
Yeah, if you don't mind, I certainly want to take the opportunity to pick your brain about this. First of all, thank you for this. It was really, really, I mean, there's all topics that, you know, we've been exposed to in various ways over the last few years, but you really brought it together, made it very powerful, and certainly lots of things here for me to remember and also work with. So thank you for that. The question I had for you, so I was thinking about, you know, of course, there's lots of the stuff that, lots of the things that you talked about are applicable in life, you know, as well as education. And as I think about a lot of the simulation activities that, you know, I've been part of, either as a learner or working in the development of simulation or studying simulation, like these things just don't really show up in the way that obviously they need to. And I was going to pull up that simulation textbook to see if any of this stuff is in there. I can't remember if it is or if it isn't, but I feel like it isn't. And if it is, it's probably not in the same depth that you just gave. So I wondered if you had some thoughts about how we transition this community into having this being truly integrated in the way that we think about simulation, the way we do simulation, the way we debrief simulation, you know, all of these things.
Well, Walter, I think just even by starting these conversations, like even having me come and participate with this I hope has stimulated conversation. I know Sim Expo last year was a launching point because for me, yes, I had been engaged with the Sim community, but last year's Sim Expo, where EDI was really brought as a thematic area, allowed for some of those early kind of conversations. And I think we need to create the spaces for those who really understand the methodology, the strategies, the technology pieces, to wrestle with, can we do more with this than refining some of the procedural things? And not to discount, because believe me, if I need somebody who's got procedural skills, I want to know that they've done it on a sim before they come to me. But I think there's huge yield potential and huge return on investment potential by thinking about these concepts and this methodology within this space, because it's been untapped, at least within the health domain. And so I think there's a lot of opportunity for us to have these conversations. Remember, I don't fully appreciate all this nuances of the technologies and the methodologies, but that's why we have to bring spaces where all these individuals are together and say, here's our wicked problem. How do we want to wrestle with this? How do we want to explore this? And what are some unique facets? And let's try it out and find places where we can try these things out.
But Agnes.
Thanks so much,
Hand up.
Jerry. Awesome talk. Thank you. I'm here from Sunnybrook. So wanted to let you know that we have started some of this work, and we did start recognizing that a lot of our facilitators and our team does not have lived experiences in this space. So we've gone through educational opportunities to try and educate and understand it a little bit more, and then connected with key stakeholder groups in the organization to advise on various aspects. And now we're ready to translate this into actual sims beyond what are the pronouns that this patient prefers. Have you asked them? Like, so we are coming from the space of curiosity. Where we're still challenged, and what I'm as a director concerned about, is the psychological safety of the learners and the facilitators, because we have done some early tries and it has gone so-so, because this is a triggering topic. And I don't have a crystal ball. I cannot predict all the triggers and all the folks lived experiences. So it's very different than our traditional Sims. It's not the same psychological safety. And then that snowballs into the psychological safety of the facilitators, because if someone is triggered, then it affects the team, then it affects the facilitators. And also, how do we mitigate ensuring that our facilitators know how to manage these situations, because we don't know what we don't know. And I know I'm saying a lot. And,
No, but Agnes, you're
experiences. So any tips, any thoughts, any insights from anyone on this team is how do we move that, to step 5 or further?
That's a great set of questions and comments, Agnes. I appreciate you sharing it. But that's just showing the messiness of this space. And because people haven't actually even started that kind of process, now it feels like we're just throwing stuff onto the whiteboard, capturing ideas that then we are going to have to start saying, okay, what do we have to do first? And what do we have to wrestle with? Like, how do we prepare our facilitators so that in case these kind of things happen, how do they provide safety? You mentioned the learners. How do we prep for them? None of these things have been articulated. We know how to do that when it comes to a traditional sim for procedural and other sort of medical things, but we haven't done that to the same rigor and with this space. So I think this is like wide open for all of us as a community to say, how do we do this? And maybe that's what we do is, we come together and we say, this is maybe a reasonable or wise practice kind of strategy to doing this kind of work. And because I think part of this also still has to be firmly entrenched with humility and curiosity and listening, because this is not an algorithm or it's not an ACLS guideline, right? And that's what you're going down the steps.
Do this and that.
You do this and do this and that. It will not work. You have to actually instill, and that's why this is really tough. You have to instill reflectivity and humility and curiosity into each individual that's participating into this space, and have individuals that are coming where there's a willingness to learn in a space, to find themselves checking themselves, but also for for colleagues to actually say, okay, I think we need to take a time out and let's explore what we're hearing, and for people to know that they're doing this within the confines of safety. I think, I'm not too sure who said it earlier, but if our usual approach is, okay, let's go to the bedside and just do this, that's not good enough, because there's a lot of harm that happens in those kind of spaces. We're trying to create a safer space to actually say, you know what, Paddle, I don't know what I'm clearly not seeing what you're seeing. Help me understand, right? What did you see that I didn't see? How do you think, what questions do you think I could ask? And we have to create the space where things are flattened enough that oftentimes in this kind of space, the learners may not be as far behind the faculty as we think, right? In more traditional type of things, there's a bit more of the gradation, right? Clearly, the staff person is, got much more expertise in certain areas compared to the student. But in this kind of space, it's actually maybe a bit more flattened than we think.
And that came through in the AMI conference. A lot of the topics that they covered were patients and trainees as partners.
Right.
So that flattening of the hierarchy when you want to explore this kind of realm.
So all to say, Agnes, I don't have an answer because I don't see it in the literature yet. But that means we need good people to come together and say, what do we need to do? How do we break this apart?
I think you're hitting the nail on the head. Is we need people to come together. And here's the problem that I'm seeing. It's exactly what we see in the sim.
Yeah.
Somebody give the epi, and nobody gives the epi, right? So we've been saying we need to come together forever, and we're doing these talks, and all the folks on this call like have given, not all, I don't know everyone, but many have given great talks, and we've attended them, and we're exploring some research. I think in simulation, we're very siloed still. I love this network. The reality is we're very siloed. So we're doing some simulations, you know, Petal, you're doing some simulations. We haven't come together, because I would love to tell you about how how one of our simulations semi-bombed. Like, I don't want to say it just,
No,
but
but
shocker. It was a shocker. And in my wildest dreams, I didn't think that just showing a video and then talking in a breakout room would create such a trigger, and a trigger that had like mammoth impact. And then us facilitators were like, we don't even know how to damage control. We wish we could say leave meeting, and we can't. And so as a facilitator, you're like, and then I'm still traumatized a year and a half later after it. And then you feel terrible because you talked about safe strategies and safe spaces, and yet you couldn't even predict. So I would love to share that with our group, and I'd be the first one to say, look, I tried it and it kind of like went sideways for me.
So Agnes, I think that you're opening something that needs to be addressed. I'm going to have to hop off, but what I was saying when I said to Jerry, you know, I still have to read your full bio, and I'm not kidding. We need you to come back and do another SimCity rounds. But I'm thinking maybe we make it a bit more panel interactive, where we kind of talk about scenarios or sort of incidents that have occurred, and then we navigate it with curiosity and humility. Maybe that's something we can think about for another rounds. What do you all say? Agnes, you're up.
I would be happy to do, and I think part of it is, Petal, that we've got a group within our EQHS lab, and we're international, and we're wrestling with these things. So perhaps, and I would argue that these kind of conversations are tough to do on Zoom. There's a lot of body language and a lot of other things, right? That that
need to be captured.
May warrant us to just say, let's get together for a half a day,
yeah,
or a full day. And if you gave us enough warning, myself and others would likely come from the EQHS lab to participate, and I would love to collaborate. Like, this is a collaborative opportunity to say, what would we put out there as strategies to move this kind of work forward, because it has to be done. There's too many unfortunate, and Agnes, and thank you for sharing that vulnerability to share is not often experienced. People say, okay, well, we'll share the successes, but lock down the ones that didn't go well. Sideways, yeah, exactly. No, don't talk, don't mention it, don't tell anybody. And as a result, we don't learn from it.
So I can start an email chain with
from like this experience. And for me, I look at it, yes, did it not go well? Am I going to report this to the CEO? Actually, I would actually tell the CEO, this is my learning experience. We realize that this is a lot tougher than we think it is. I realize that as someone who does not have this shared lived experience, I have to really be mindful about it and who I engage. I can't just talk about this like I talk about insertion of a CVC. So I really like what you said, Jerry. I would be open to in person. I don't think I'd want to discuss this like on Zoom. I think our psychological safety is also critical when we talk about these topics too.
So maybe we need to do a retreat of some kind, like Jerry's suggesting. All right, well, leave it with me. I'm going to introduce you all via email so you can keep this conversation going. And thank you both so much. Jerry, we'll chat soon. Take care, Agnes.
Thanks so much,
everyone, for coming. Bye.